So this session is about controlling labor pain. Labor is generally a very painful experience for a mother who has come for delivery. And it is a very distressing experience for the spouse and the family. And it is a challenge to the obstetric staff also, both for the labor room staff, nurses and midwives, and for the obstetric doctors. Hence, attempts are always made to control labor pain. Labor pain can be controlled in many different ways. The most widely used method in Sri Lanka is administering IM opioid, and the most frequently used drug is pethidine. So pethidine is administered at a dose of 1 milligram per kilogram body weight as an IM drug and accompanied with an intravenous antiemetic like ondansetron 4 milligrams or 4 to 6 milligrams for an adult, or metoclopramide 10 to 20 milligrams. Another useful method is trying to control pain by Entonox inhalation using a on-demand Entonox valve. And the more suitable and an ideal labor analgesic would be trying to use an epidural labor analgesia using local anesthetic agents together with an opioid like fentanyl. So as I mentioned earlier, labor epidural would be a better analgesic for a laboring mother. However, when you administer a epidural, the situation that you will encounter could be of two types. One group of patients, you will be starting a labor epidural well before they start pains. So you will get a very calm, quiet patient to whom you have spoken to, you have explained what the procedure is going to be, and still she hasn't got a lot of pains, or there may be an occasional contraction, and now she is quietly placed on the bed and you have a very peaceful, calm environment, and you are embarking on the epidural. You have assistance, you have drugs ready, everything is fine, and at the end even the patient might not know what normal labor is, and she may complete delivery. Next situation is where you can encounter a patient who has gone halfway through labor procedure, or at least first 1/3 of labor, and she has experienced pain and she is in tremendous distress by now. She's crying, shouting, yelling, calling for help, and at the same time when you try to start an epidural, she is not cooperative because she is so distressed and painful. She can't stay still for you to do the procedure, and doing an epidural in a situation like that is very difficult, and you need a lot of experience and training to do an epidural properly in a situation like that. So in a situation like that, you will have a very cumbersome environment around where the staff is trying to control the delivering mother, and she is not coping up, and they are trying to put the patient down on the bed. She is getting up and she can't stay still. She's getting contractions, and as she gets contractions, she's shouting in pain, and you are getting ready for a procedure for which you ideally need the patient who is very still, because you have in your back of your mind that if the patient moves vigorously, you are going to cause a dural tap, and that is something you don't want in a laboring mother. You want to stop in the epidural space, and however, you have arranged your drugs and the epidural trolley, and you are going to start an epidural. So in the next video clip that we are going to show, you will see a mother who is the type of mother you will get if you start an epidural halfway through labor, but which again is very rewarding if you are very successful, because she has felt pain and she is demanding for help, and that is where your skill and managerial skills and procedural skills work, and you can get going with a good epidural and relieve her pain. Right, so this is a typical situation where you have come across a patient who has gone into labor, and now the patient is struggling, in pain, crying, asking for help, and you are expected to do a quick epidural. Since epidural anesthesia is done under strict aseptic conditions, you have to pay your attention to maintain sterility throughout the procedure. So first thing to do is to have a sterile drape over the trolley. Lay your items that are essential for the epidural on the trolley. So the items essential are: you need an epidural set or combined spinal epidural kit. You have to have local anesthetic agent, bupivacaine for the epidural, and fentanyl and cleaning solutions. Right, next step is to position the patient. So this is a very challenging situation. You have to do a fine procedure like an epidural. You want a patient who is still. And on the other hand, the patient can't stay still. She's in pain, she's struggling. So now you wait till the patient is free from a labor contraction, and then you get in your epidural in. You can do the epidural in two positions, either when the patient is seated or when the patient is lying on a side. When you do the epidural on a side, that position may be slightly easier for the mother, but for the person who does the epidural, sometimes it might be a little difficult to find the midline. Whereas when you keep the patient seated like this, finding the midline and going by the landmarks, anatomical landmarks are easier. But if the patient starts getting contractions of the uterus, then she might find it very difficult to sit like this. So next is cleaning and draping. Epidural has to be performed under strict aseptic conditions. So clean the back of the patient first with povidone iodine and wait for povidone iodine to act. So generally you have to leave about 3 minutes for iodine to act properly. Next is to clean with surgical spirit. And after applying spirit also, you have to wait for 45 seconds to 1 minute, or at least spirit dries out for spirit to start acting properly. Next is to put two sterile drapes. Right, now you have to get the landmarks identified. So a lumbar epidural is generally performed at L23, L34 or L45 spaces. As you go lower, it's safer to the patient because you are going away from the spinal cord, so chances of inadvertent injury to the spinal cord is less. However, performing the epidural is easier as you go up in the lumbar vertebral space. So you first identify the intercrestatic line, the horizontal line you draw joining the two iliac crests, which generally falls on L4. You can go one space below or one space above or two spaces above. Next is to inject the local anesthetic solution. If you can get the mother to bend her head forwards and to curve the back a little towards you, then you can open the intervertebral space. Then injecting the local anesthetic solution and doing the epidural is easier. So draw the local anesthetic solution, generally 2% plain lignocaine, that is lignocaine without adrenaline. Undiluted solution 3 to 5 milliliters is enough for local anesthesia. Draw it into a 5 milliliter syringe. Use the smallest possible needle with the intention of causing no pain at all or minimal possible pain to the mother. So inject only a very small amount to get the skin blade. Wait for that to act. So you have to wait for about 1.5 to 2 to 3 minutes for local anesthetic solution to act properly. Then go through it again with a very small needle and then inject the underlying layers of the skin and anesthetize all subdermal layers. To get the skin blade, a 27 or 26 gauge needle is good, and for layers below that, 22 to 25 gauge needles are appropriate. So mount the epidural syringe onto the epidural needle with about 5 milliliters of air or saline drawn into the syringe. Now you are trying to elicit the sign of loss of resistance, and you are going through different layers of tissues under the skin. As you go passing the ligamentum flavum and enter the epidural space, there will be a sudden loss of resistance, and the contents of the epidural syringe would be delivered into the epidural space, whether it is air or saline. And then you can keep the epidural needle still in the epidural space and gently remove the epidural syringe and see whether there's anything coming. So there should not be CSF coming. If CSF is coming through the needle, that means you have gone through the dura. If you are doing an epidural, the needle should stop outside the dural space, which is why you call it epidural or extradural. Next is to inject the local anesthetic solution. If you can get the mother to bend her head forwards and to curve the back a little towards you, then you can open the intervertebral space. Then injecting the local anesthetic solution and doing the epidural is easier. So draw the local anesthetic solution, generally 2% plain lignocaine, that is lignocaine without adrenaline. Undiluted solution 3 to 5 milliliters is enough for local anesthesia. Draw it into a 5 milliliter syringe. Use the smallest possible needle with the intention of causing no pain at all or minimal possible pain to the mother. So inject only a very small amount to get the skin blade. Wait for that to act. So you have to wait for about 1.5 to 2 to 3 minutes for local anesthetic solution to act properly. Then go through it again with a very small needle and then inject the underlying layers of the skin and anesthetize all subdermal layers. To get the skin blade, a 27 or 26 gauge needle is good, and for layers below that, 22 to 25 gauge needles are appropriate. Next is to start doing the epidural proper. So you get the epidural needle to your hand, which generally is a 16 or 18 gauge epidural needle, which is about 8 centimeters long. Generally, the depth to the epidural space is about 4 to 5 centimeters with the bevel vertical. So if by chance you damage the dura, then the injury to the dura is minimal if you have entered with the bevel vertical. So you have to elicit a sign called loss of resistance. What do you mean by loss of resistance sign? As you go through the skin and the underlying layers through the ligaments, you will see and you will feel a resistance. And the resistance will increase as you go through the supraspinous ligament, interspinous ligament, and when you reach the ligamentum flavum, the resistance you feel with the needle will be maximum. Soon after you pierce the ligamentum flavum and as you enter the epidural space, you will feel a loss of resistance. This is the sign called loss of resistance. You can elicit this when you are experienced using the syringe and a needle. After verifying correct positioning of the epidural needle in the epidural space, now is the time to thread the epidural catheter in. As I mentioned earlier, generally the depth to the epidural space is about 4 to 5 centimeters, and you are planning to leave the epidural catheter in about again 3 to 4 centimeters. So after threading the epidural catheter in through the epidural needle, finally the skin level at the epidural catheter should be about 8 to 10 centimeters depending on the depth to the epidural space. After placing the epidural catheter in the epidural space, apply some gentle negative pressure onto the catheter to see whether there's blood or cerebrospinal fluid coming down the epidural needle. If there's no CSF or blood coming down the epidural needle, you can be fairly sure that you are in the epidural space. But you need to perform a test dose to be definite. You can paste the epidural catheter onto the skin and put a plaster and get the distal end of the epidural catheter to the side of a patient's neck and attach the injection port to the distal end of the epidural catheter. Unlike in a spinal or subarachnoid block, we inject a larger volume of the anesthetic solution in an epidural block. Therefore, you have to be 100% sure before injecting such a large volume of local anesthetic solution into the epidural space. You have to be sure that you are not in the subarachnoid space and not in a blood vessel. After doing the test dose, you can be definite that you are in the epidural space and you are now free to start the epidural catheter using the solution that is most suitable for this patient. Generally, at early stage of labor, we use 0.10% bupivacaine with fentanyl 2 micrograms per milliliter or 0.125 solution with fentanyl 2 micrograms per milliliter. So this technique we have discussed now is good enough to keep a mother in labor comfortable and pain-free in the first stage of labor. And at the same time, she will be free to move her legs, even to stand and walk with help. We can maintain the labor epidural either by injecting boluses of the local anesthetic solution, maybe 6 to 10 milliliters of 0.1% bupivacaine solution with fentanyl at a time, or maintaining a continuous infusion through a syringe pump of a similar volume per hour, maybe 6 to 10 milliliters per hour, or using a patient controlled analgesia pump where you can use the epidural as a patient control epidural analgesia where the patient has the power to control it by injecting a bolus of the local anesthetic solution when she wants to inject and be pain free. So in summary, we saw how we could keep a mother in labor pain-free and comfortable in the first stage of labor by using an epidural catheter and a bupivacaine fentanyl mixture.